This video is for anyone who has been diagnosed with the BRCA1 or BRCA2, sometimes called BRCA1 or BRCA2 gene mutation. This means that when you look at a genetic testing report, it will say either likely pathogenic or pathogenic variant in BRCA1 or BRCA2. This is considered a positive result. So somebody who has one of these BRCA mutations is said to have hereditary breast and ovarian cancer syndrome, or HBOC. However, it also includes pancreatic and prostate cancer in addition to some other risks, and so we've more recently shifted to this HBOC-PP. You may see it written either way when you're Googling. I am Dina Goldberg, and I'm a board-certified genetic counselor with both clinical and research experience in hereditary cancer syndromes. I created this series because it kept coming up that for many of these conditions, it was hard to find information on the internet for patients. And so I wanted to create something that lived on a platform that many people go to answer their questions, which is why I'm here on YouTube. I'll be walking you through what we know about the different inherited cancer syndromes with information straight from the National Comprehensive Cancer Network, or NCCN, guidelines and other trusted and vetted medical sources. So you can go to your appointments with more knowledge and better questions. Now, I'm a genetic counselor, but I may not be your genetic counselor unless you are seeing me in clinic. So this is not direct medical advice. It is a safe and vetted resource for you to get information on your inherited cancer syndrome. Okay, so let's start with the basics. What is BRCA? Or BRCA? Well, everyone has two copies of the BRCA1 gene, so one from mom and one from dad. And the same goes for BRCA2, one from mom and one from dad. They're separate from each other. The normal function of the genes BRCA1 and 2 is to fix broken DNA and protect cells from becoming a cancer. All of these cancer genes are actually good genes. We all have them, and we need them to protect our cells in some way from becoming cancer. The issue is when they stop working correctly. The BRCA1 gene gives information to code for the BRCA1 protein, and the same goes for BRCA2. Both help keep our DNA healthy and stable. These are referred to as tumor suppressor genes, meaning that they help prevent cells from growing out of control and turning into a cancer. So these two proteins basically team up with other proteins and form a repair crew that finds and fixes broken DNA. When the BRCA1 and 2 genes are not functioning correctly because of a harmful mutation, the body's ability to fix DNA becomes reduced. This increases the chances that cells can become cancerous over time. There are many slightly different variations of BRCA1 and 2, slight variations in the spelling of the BRCA1 and 2 gene, some of which are linked to increased cancer risk and some are not. Some are just normal variation. So a pathogenic or likely pathogenic version of one of these genes means it is not functioning correctly, which increases cancer risk. We consider this a mutation or a disease-causing genetic change. Now, BRCA1 and 2 were discovered in the 1990s by a team of researchers led by Dr. Mary Claire King. It was the first major breast cancer gene that was identified, which paved the way for further research and further discoveries in hereditary cancers. And today we know of many genes associated with cancer risk. Now, how common is it? In the general population, we estimate that about 1 in 400 people are a carrier of a BRCA1 or 2 mutation. However, that risk goes up by 10 times in people who have Ashkenazi Jewish ancestry. If you don't know what that is, Ashkenazi Jews are Jews that have the more recent ancestry from Eastern Europe. Now, in certain groups, like Ashkenazi Jews, we have what are called founder mutations, and that means that they are very specific variants, much higher frequencies in that population. There are 3 specific ones we know that are very common in Ashkenazi Jews. We also know that there are some founder mutations in other communities as well. In the general population, as I said, it's about 1 in 400, and the Ashkenazi Jews, 1 in 40. Now, BRCA1 and 2 mutations are also found to be higher in the Black community. And there's many studies showing that it's probably somewhere between the rate of the general population and the Ashkenazi Jews. And there are other populations that will have their own founder mutations. So if you're interested, it might say on your report where your mutation's from. What are these risks I speak of? We're going to look now at the most up-to-date National Comprehensive Cancer Network guidelines to understand what the risks are for the different cancers with both BRCA1 and BRCA2. They're a really great expert consortium that looks at lots of different well-done studies to understand a summary of what the risks are with different gene mutations. I'm going to first read the population risk and then go over the absolute risk. And just to preface this, this is a risk range. So there's going to be a range. Some of them are small ranges, some are large. And the reason there's a range when it comes to this risk number is because it's really based on a number of different studies. And so one study may find a risk is lower and one may find it's higher. When you look at all these studies together and you take all this information together, you're really given a range. And so the number itself isn't what's as important, but it's understanding if your risk surpasses a threshold that extra intervention would be helpful. And that's what this is all about. So it's not about a number per se. It's about understanding if you would benefit from doing extra screening or extra clinical actions because your risk is increased. I don't want you to focus on the number. I want you to just kind of think about, is the risk increased to a point where it makes sense to take this clinical action? So when we think about breast cancer in the general population, most women will have about a 12% average risk for developing breast cancer in their lifetime. 12%. That's 1 in 8 women. However, those with BRCA1 mutations will have about a 60 to 72% risk, and those with BRCA2, about 55 to 69% risk. So that is a greatly elevated risk, which is why we recommend that people with these mutations are on an elevated screening protocol or will opt for surgical intervention. But what does that mean? So the protocol for those who have BRCA1 or BRCA2 mutations will include the following. So the first is beginning at age 18, we recommend that these individuals be very self-aware of their breasts. And that means knowing what their normal is, what normal feels like. Do they have lumpy breasts? Do they have dense breasts? Knowing that so that you know your baseline and therefore can possibly feel if something feels off. That's number one. Number two are clinical breast exams. That means going in and having your physician feel and do a breast exam. I usually tell patients to ask your physician to teach you how to do one so that you really know how to feel your own breasts and how to feel for what is normal. The clinical breast exam should happen every 6 to 12 months, beginning at age 25. And then we have annual breast MRIs. I kind of think of this as two different paths you can take. You can do the screening path or you can do the preventative surgery path. And they are both options that are going to be right for different individuals. What's right for one person may not be right for another. I'm going to talk about the screening path first, and then we'll talk about the surgical prevention. So for screening, what that would look like would be annual breast MRI. So that's a breast MRI every year beginning at age 25, and then adding in annual mammograms at age 30, typically alternating every 6 months. That way you are visualizing the breast with mammography, but also with an MRI, which actually look at the breast tissue in different ways and can pick up different things. So if you're alternating every 6 months, then you are really getting a well-rounded view of your breast tissue. Now, MRIs can be done before 25 when there is a family history of an early onset breast cancer. So if somebody had breast cancer in their early 20s, then we would recommend their relatives may start screening earlier than 25, but only with MRIs, not with mammograms. There's also 3D mammography with tomosynthesis, which NCCN suggests as preferred when it's available, and breast MRIs with contrast. This is contraindicated in patients who have kidney issues because of the contrast or any other reasons that they shouldn't have contrast. That's something to talk to your doctors about. Now, breast ultrasound is not really routinely recommended, but may be used for those who can't undergo MRI for a specific reason, and sometimes is even used in addition to this recommended screening, depending on the screening center. It's just not part of the general recommendations. So that's the screening protocol that we typically talk about, but then there's also the surgery route. The surgical route is something called a risk-reducing mastectomy, and that means removing the breast tissue so that there is a much lower chance of a person developing a breast cancer because they have a lot less breast cells. Now, this never completely eliminates the risk, but it greatly reduces it. And there are pros and cons to doing both of these things because it is a major surgery. However, some people really don't like the screening because their breast tissue is harder to visualize and they end up being called in to have a biopsy if they find something that looks abnormal. And once you do that a number of times, it can cause a lot of anxiety in some people. And other people really just don't want to do the surgery, so they opt in for that screening. And you can also screen until you decide to do the surgery. Some people may think about wanting to breastfeed, and so they would like to delay a surgery until after they have that opportunity. And others may find that, no, I want to get this done right away. There's just such a variety of thoughts with this. And so this is a very personal decision, and there's no right option. There's only a right option for you. This is where patient groups can be so helpful, where you can talk to others who've made different decisions and talk to your providers and really understand all of the options out there. Because you can also have a mastectomy with reconstruction, or you can stay flat. There's so many different options out there, and you want to make sure that you are being given all the options for you and that you understand them and that all the opportunities are available so that you can choose what is right for you. Now, in addition to this, there are some medications that can be prescribed to also lower the risk for breast cancer, but they all have side effects, so it is really important to talk to your doctor about doing them and what the side effects are, and if the risk reduction is worth it for you. And typically this surgery would be covered by insurance if you have a BRCA mutation because it is a national recommendation. We also have the risk for a secondary breast cancer, what we call contralateral breast cancer. And in the general population of people who have had a primary breast cancer but don't have a known genetic mutation, that rate of developing a secondary cancer is about 2% within 5 years of diagnosis. However, if you have a BRCA1 mutation, the 20-year cumulative risk, so the total risk over 20 years after having a primary breast cancer, is about 30 to 40% of developing a second one. And in BRCA2, that 20-year cumulative risk is about 25%. So pretty high of developing a secondary breast cancer, which is why this information is so important when a patient has developed a breast cancer and is deciding on their surgical treatment. Because if you know your risk for a second breast cancer is not that high, then a patient and their team may decide that it's not worth removing the other breast or doing a more extreme surgery. But if you know your risk for a secondary breast cancer is much higher and you don't want to go through that again, you're much more likely to do the full mastectomy. So take out as much breast tissue as possible. That's one of the reasons it's so important to know if somebody has a BRCA mutation before making a decision about their surgical treatment when they have a breast cancer. So now let's talk about ovarian cancer. This is what we call epithelial ovarian cancer, fallopian tube cancer, primary peritoneal. These are all lumped together in the same group of risk for these individuals because it's really all coming from the same types of cells. In the general population, only about 1 to 2% of people will be diagnosed with this, but in those with BRCA1 mutations, it's about 39 to 58% of a chance, and in BRCA2, it's 13 to 29%. Ovarian cancer is a really tricky one because it's very difficult to detect early. Unlike other types of cancers where we do find it early because it's either symptomatic or we have good screening for it, we just don't have that for ovarian cancer. And so the best way to greatly reduce risk is to have surgery to remove that tissue, the ovaries and fallopian tubes removed, when somebody is done having children. Now, that being said, when you remove your ovaries, you go into what's called surgical menopause, which means that you're no longer able to produce the hormones that somebody who is menstruating may have. And so instead of going through this natural menopause, you will go through it after the surgery, and that can be tough on people. It's a really important discussion to have with your healthcare team to really understand the benefits and limitations to doing an earlier oophorectomy versus later. It's balancing the risk of ovarian cancer. And then there's also the option for doing what's called a self-injectomy or a fallopian tube removal before the ovaries. And the benefit of that is that a large amount of ovarian cancer actually begins in the fallopian tubes. So if you remove the fallopian tubes before you remove the ovaries, you're not putting somebody into surgical menopause. So they'll still be making the hormones. Their body won't be needing to adjust in a way that it would if you were removing ovaries. It's called self-injectomy with delayed oophorectomy, and you can be part of a study. There are different surgical choice studies you can be part of. It is strongly recommended. If you are delaying when you are having your ovaries removed, about what age should this happen? So the NCCN talks about those with BRCA1 mutation. It's recommended to have the risk-reducing salpingo-oophorectomy, or the fallopian tubes and the ovaries being removed between ages 35 and 40. You can slightly delay if you're taking out the fallopian tubes. And for those with BRCA2 mutations, because the ovarian cancer onset in patients with these mutations is an average of 8 to 10 years later than those with BRCA1, age 40 to 45, unless there's somebody in the family who was diagnosed earlier. Another thing that doesn't always get discussed is hormone replacement therapy, or HRT. And this is so valuable for so many people that are going through this surgical menopause, that are having their ovaries removed. It's a lot on a body to adjust to an absence of hormones. So recently there's been this influx in the use of HRT in menopausal women, but especially in those who have gone through surgical menopause. It just has been shown to greatly improve quality of life. And of course, there may be some contraindications, so it's really important to have that discussion with your doctor and with your surgeon when you're making that decision. Even with doing these surgeries, there of course will always be some small residual risk of still developing a cancer, because you can never really remove 100% of a certain organ's tissue or cells, but it is greatly reduced. Now, ovarian cancer is very difficult to detect early, but that may change in the future as we're learning more about lots of different new ways for early cancer detection. And I am really hoping ovarian is on that list of what becomes available. There's actually limited data on whether individuals with BRCA are at an increased risk for uterine cancer, a very specific type of cancer called serous endometrial cancer. But because it's being studied, it's something that some patients will choose to do when you're already going in and you're having a surgery and you're removing those organs and you're not going to have a child after that. You can also have your uterus removed. A full hysterectomy, so that's the uterus, the fallopian tubes, and the ovaries, when somebody is done having children. So now let's talk about pancreatic cancer. In the general population, only about 0.5% of people will be diagnosed with pancreatic cancer. However, if you have a BRCA1 mutation, that risk jumps to under 5%, and with BRCA2, it's about 5 to 10%. Pancreatic cancer is another one, like ovarian cancer, that's very difficult to screen with our typical screening methodologies, and it's typically caught at a later stage and tends to be pretty aggressive. We don't typically recommend pancreatic cancer screening because we don't have a standard, but there's a lot of research that's been done over the last decade or so on whether screening for pancreatic cancer is helpful in detecting it earlier. These studies are still being run. So for BRCA1, we recommend screening only if there's a family history of pancreatic cancer in a first or second degree relative who also has that mutation, or who's on the same side and is assumed to have that mutation, beginning at age 50 years or 10 years younger than the earliest pancreatic cancer diagnosis in the family. So there's not a lot of data on whether it's really worth it to screen BRCA1 mutation carriers who do not have a family history of pancreatic cancer. So it's something that could change over time, but as of right now is not part of the recommendations. Now for BRCA2, that same screening is recommended for anybody regardless of family history beginning at age 50 or 10 years younger than the earliest pancreatic cancer in the family. Endoscopic ultrasound, which is a scope that goes in through the mouth and into the stomach and has an ultrasound probe on the end of it that looks through the lining of the stomach at the pancreas. So it gets a really good close view and does an ultrasound there, or an MRCP, an MRI of the abdomen that's looking specifically at the pancreas. Those are the two screening methods that are recommended. And that screening should be done at a center where they really specialize in high-risk pancreatic cancer families and in screening. There are many academic centers across the country that offer these high-risk protocols, and you can even enroll in research, which is really helpful because it helps everybody. It helps us understand whether this screening or another type of screening would be better and what the future may look like for pancreatic cancer screening. Now let's talk about prostate cancer. If you didn't know this, prostates are organs that are only found in men or those who are male assigned at birth, and prostate cancer is a very common cancer in the general population. Usually it's very slow growing. We say that most men will die with it, but not from it because it is slow growing and it happens in so many. However, when somebody has one of these BRCA1 or 2 mutations that cause the prostate cancer, that prostate cancer tends to be more aggressive and faster and should be treated differently than what we think of as the garden variety prostate cancer. So it's really important to know, which is why there's been this movement to test everybody with prostate cancer for BRCA mutations, because it will help their healthcare team really make personalized decisions based on that information. The NCCN now recommends discussing the use of prostate-specific antigen testing, or PSA, in addition to digital rectal exams annually if a person chooses to screen. And that's usually beginning around age 40. Now let's talk about male breast cancer. In the general population, the risk of male breast cancer is about 0.1%, so pretty low. Yes, it can happen, but if you have a BRCA1 mutation, the risk for male breast cancer is about 0.2% to 1.2%, and for BRCA2, it's 1.8 to 7.1%. both by age 70. So you can see it's not a huge increase in risk, and it's not anywhere near what the female breast cancer risk is, but it's still elevated. So in those who are male or assigned male at birth, the NCCN suggests regular self-breast exams. But what I tell patients is typically to talk to their doctor about how to do a self-breast exam, how to understand what their normal feels like. And in men with breast cancer, it is sometimes easier to feel a lump because there isn't the same fatty tissue there in many of them. And so they may find it sooner. And so if you do find a lump, go in, talk to your doctor about it. Make sure that you get worked up for that. And that regular self-exam should start at age 35. And then clinical breast exams when you go in to see your primary care doctor every year. Then we have this risk of melanoma. And although the NCCN only really lists it under BRCA2, because it is really easy to do full body skin checks and to see a dermatologist, a lot of BRCA1 mutation carriers will also do the melanoma screening. The recommendation is to do total body skin exams. And that means they are looking at you without clothes on. They are looking in your hands, on the bottom of your feet, in your scalp, around your ears, even in your mouth. And another thing about the melanoma risk is that anytime somebody has an elevated risk, they can also develop it in their eyes and in their mouth. And so I usually talk to patients about just telling their dentist that they have this increased risk. So if they find any spots when they're in their mouth, to let them know. And then if you're having an eye exam, to look for any evidence of uveal melanoma of the eye. Now, these are not necessarily increased risk, but if you have an increased risk for melanoma and you're already doing these exams, it can't really hurt to just let them know that you have this risk and they should be looking there. Now, if there is uveal melanoma in a family, then having eye exams about every 1 to 2 years to check for signs of it is really important. And then there's safe sun practices. So wearing sunscreen, wearing clothing that's UV protective, wearing hats, things that protect your skin from UV rays. If you see a mole or you see something growing on your body that wasn't there before, or it looks like it's abnormal or growing very quickly, letting your doctor know, going into that dermatologist and having them check it, because it's better to be safe than sorry. And really anybody can develop skin cancer, whether you're at an increased risk or not. I used to tell people that there were dermatologists that really focused on cosmetic procedures, and then there are other dermatologists that are focused on cancer risk and cancer prevention. And those are going to be the types of dermatologists that will be best for tracking any changes. And some will do mole mapping, where they record where all of your spots are and they take pictures and then they map them over the years so they can see how they grow. There's a lot of really cool technology now in skin cancer prevention, so it's something worth talking to your doctor about. Now let's talk about BRCA1 and 2 mutations and somebody who does have a cancer. Are there treatments that are different? Yes. PARP inhibitors. A PARP inhibitor is a type of medicine that's used to treat certain cancers, especially in people with BRCA mutations. It works by blocking a protein called PARP that helps cells repair damage to their DNA. Cancer cells with BRCA mutations already have trouble fixing DNA, so when you block PARP as well, the cancer cells actually can't repair themselves and will eventually die. This treatment is designed to target cancer cells while leaving most of the healthy cells alone. PARP inhibitors are used for some breast, ovarian, prostate, and pancreatic cancers and have been shown to be more effective than other treatments that are typically given. And so knowing if a cancer has a BRCA mutation is really, really helpful when we're talking about personalized treatment. Okay, so we've talked about what this gene is, what it means for you if you have it. Now, what about your family members? What about if you are planning on having children and you just don't want to pass this down? Well, it is possible. There are technologies to help you with that. When you are born with a BRCA mutation, it exists in every cell in your body. So when you have children, you have a 50% chance of passing your normal copy and a 50% chance of passing the abnormal copy. Each child is like a coin toss, flipping a coin. These mutations do not skip generations. So once a child does not inherit it, it will not be passed down unless it's coming from the other partner. Because of that, a lot of people will opt into something called IVF with PGT-M, which stands for in vitro fertilization with pre-implantation genetic testing for monogenic conditions. And in these cases, people who have a known BRCA1 or 2 mutation, or really any gene mutation that can be detected, can actually prevent it from being passed down by creating embryos, growing out the embryos, and then testing the embryos to see if they have that mutation or not, and only implanting the ones that do not. And this ensures that this mutation does not get passed down and stops it in its tracks. So that's a very popular option, but not an inexpensive option. So not the right thing for everybody. Anybody who has a mutation in BRCA1 or 2, their partner should also be tested, because in the off chance their partner also has a mutation in the same gene, so both in BRCA1 or both in BRCA2, then there's a chance that they both pass down that abnormal copy. And if a baby is born with no functioning copies of either BRCA1 or BRCA2, then they will have a condition called Fanconi anemia. And it's a recessive condition that's pretty severe and affects bone marrow and other parts of the body. And people with Fanconi anemia have an increased risk for many blood disorders and early cancers and physical abnormalities. It also affects other organ systems. And so we always want to ensure that there's not this chance of a couple passing down Fanconi anemia. However, if one partner is a BRCA1 carrier and the other is a BRCA2 carrier, that together doesn't cause Fanconi anemia. So what do you tell your relatives? We encourage you to speak to your relatives about this. If you are found to have a BRCA1 or 2 mutation, then each of your first-degree relatives has a 50% chance of also having that same mutation. So it's really important for them to know, for their own medical care, for their own healthcare providers to know this information. And although it can be really scary sometimes and feel like you're burdening them with this information, they have it whether you tell them or not. Working with someone like me, a genetic counselor, or another healthcare professional in genetics, part of our job is helping our patients communicate risk to relatives. And we can give you something called a family letter, where you can actually share direct information with your family without really needing to discuss much. And sometimes you don't even need to talk at all. You just send the letter and it explains what you have, what their risk is, and how to get tested. You can't force somebody to get tested, but you can give them the information so that they can make their own choice as to what to do with that information. I've heard people say, oh, well, I'm just going to tell my daughters, or I only have sons, it doesn't matter. But it's so important for men to know, because there are cancer risks in men, even though they're not as high as in women, but also they can pass on these mutations to children. And there are ways to prevent that. As I mentioned, everybody in the family that has this should know about it. They should be aware. And it's very easy to get testing these days, especially when there's a known mutation in the family. If you're having any problems getting testing or talking to your relatives, then I would recommend finding a genetic counselor. And I'll put links in the caption as to how to do that. So I have given you a lot of information today, and it can be very overwhelming. A lot of these decisions are very difficult decisions. Something I like to recommend to my patients is joining support communities where you can talk to others who are in a very similar life phase or a similar situation, have a similar background or culture, and maybe they're farther along in their process and they can tell you what they've learned. Maybe they're at the same point as you and you have somebody who's going through the same thing as you. It's so helpful to find these support communities. Some of the support communities I love are the Breasties, force, share it, and I'll put more in the caption. To be able to find your community and a community of people making the same decisions, thinking about the same things as you, is priceless. It is so valuable. The other thing is that everyone at some point will benefit from seeing a therapist, because everyone at some point in their lives will have to go through challenging times, will have to make big life decisions, and a therapist is trained in helping you and your mental health and helping you parse through these decisions and figure out what is right for you. Consider seeing a mental health professional who's familiar with hereditary cancer or making big health decisions. This would be the time to do it when you're making these choices about surgery, about screening, and you're having any anxiety about these results. Learning that you have a BRCA1 or BRCA2 mutation can be a lot to take in, but knowing your risk is powerful. You can work with your medical care team to take steps to greatly reduce your risk for developing cancer. Check out the links in the description for trusted resources. And if you want to learn more about any of the other genes in this series, make sure to subscribe and watch the next video. I hope that was helpful. Visit findageneticcounselor.com to find a genetic counselor near you, and I'll put additional links in the caption.